My name is Sue Grinnell, and I'm with the Public Health Institute, and I'm going to be kicking us off this morning. We are going to be recording this presentation, and then the slides will also be available once we're, excuse me, complete. So for those of you that, wanted to listen to it again, or, some of your partners. So we're going to be doing a screen share on Zoom. I don't know how many of you use Zoom, so we'll be, sharing the slides here today. And if you want to go ahead and great. Okay, go ahead and advance. So we wanted to start with introduction. So, like I said, I'm Sue Grinnell, and I'm at the Public Health Institute. One of the projects that I work on is I get to work with the accelerator sites, and another project that I'm on, we're going to be sharing a bit about with you today. And so up here we have our team. So Kevin Barnett is the co-PI and senior investigator, and really an expert in this issue of community benefits. So very fortunate to get to work with him. And then you're going to hear from Eliza Love, who is newer on the team, and she's our lead data wizard, the technical assistance analyst, and then Stephanie Sario, who's our program manager here. What I'd like to do is have folks introduce themselves. I think that I'm really excited about this opportunity to have both accelerators and catalysts together. And so, Barb, what I was thinking is maybe if you could introduce yourself and, just the team, right? But maybe call on the sites that if you know that they're on there, just to try to have some order to it. And then I'll do the same for the catalyst sites, or the accelerator sites, excuse me. So.
Sure, happy to. And thank you, Sue and Kevin, for putting all the materials together, the memo and the profiles, and for hosting this webinar for the CACHI sites. I think it's going to be a good day. So for those who don't know me, I'm Barbara Masters, and I am leading the program management with my program management team colleagues, the Catalyst communities. And I think both Laura Hogan and Pat Powers are on the call, so I'll let them introduce themselves, and then I think I see at least 3 of our communities on, so I'll ask them to introduce themselves. So Laura and Pat.
Good morning, everybody. This is Laura Hogan. I'm part of the program management team for the CACHI Catalyst sites, and glad to be on the call today.
Hi, everyone. This is Pat Powers, also with the program management team for the Catalyst sites, and I'm based in Sacramento.
Thank you. I think I saw Amy from Stockton on. Amy, do you want to introduce yourself?
Hi, this is Amy Portello Nelson, and we are leading the CACHI initiative in San Joaquin County around issues of trauma.
Sonoma, Lori Houston, I think I saw you on the list.
Sorry, yes. Hi there. I had to unmute myself. This is Lori Houston from Sonoma County, and we're leading our Accountable Communities for Health project on cardiovascular health.
Thank you. Diego from Imperial.
Hello, this is Diego Gamboa. I'm representing the Imperial County Accountable Communities for Health, and our health topic is asthma.
I'm not sure if I see anybody else's names, so I'll just go through the 3 communities quickly. Everybody is on. Merced County, San Diego County, and Santa Clara County. All right, so those are our 3 out of 6 communities. Thanks, Sue.
Great, thanks, Barb. So I'm not really able to see the whole screen, but I'm just going to call out. So I know Humboldt is on, and maybe in a couple of different places. So Humboldt, do you want to introduce yourself?
Hi, this is Jessica Osborne, staff nurse for the Humboldt Community ACH. We also have Martin Love, Patty Torres, and Carrie Escudero on the call, and our ACH is focused on substance use disorder.
Great, thanks, Jessica. Kate or Shelley from Lake, are you on? Okay, and Napa County? Okay, Sacramento? Somebody say something. Is that Deborah? Was that you, Deborah Odo Kent from SAC?
No, it's Deborah Ward with San Gabriel.
Oh, okay.
Valley.
Great, great. I've only had the name. Well, great. So Deborah, welcome.
Thank you.
And I know Fresno, they're not able to join today. Long Beach, are you on?
Yes, hi, this is Christina and Tiffany from the City of Long Beach Department of Health and Human Services, and our focus area is All Children Thrive.
Great.
Alyssa and Deborah.
Okay, great. And Riverside, I think I saw Amy Custer.
Yes, good morning. I'm Amy Custer. I'm with Citri, and we work with Riverside County, and our focus is diabetes prevention.
Great. And then, so Deborah Ward, San Gabriel, right? And I think you have a couple of other folks on?
No, I think it's just me.
Oh, okay. I thought Mickey and Alyssa, I think they're on. So, and then Heather from LA Boyle Heights, are you on? Great. And sometimes folks will join. So we're going to move to, before we kind of dive in, we wanted to do a poll. So, so we just kind of wanted to get a sense from you what kind of your knowledge or your engagement has been with, oh wait, did I mess up? Okay, with community benefit. And so we have a couple of questions in here, and Liza's going to start us off with this poll, and just take a moment to look at the questions. What's been your engagement with community and benefit? First one, like what is that? You have general knowledge, or you've partnered or collaborated with hospitals, but maybe unsure. You've been directly engaged, or involved, or you receive community benefit dollars, and I'm really unsure about how it relates to my work. So just take a moment to do that. And of course, I can't read that because it's far away.
Yeah.
Are all of the things up there? Okay. So it looks like there's a fair number in the last one, right?
So there's 3 going to, they received.
Can I ask a question?
Sure.
Hi, this is Lori from Sonoma. How do I respond to this?
There should be, you can click.
Oh, it's not, I don't see that.
Oh, you're not seeing it?
Mm-mm. But I'll just tell you, I'm C.
Okay, great.
Okay. Thank you.
Very good. Very good. Eliza, would you mind just kind of like, because I can't, it's too far away to read.
Sorry, yeah.
Yeah.
So right now, 50% of people have voted.
Okay.
So we have 10 votes in. There's 2 that have general knowledge, so 2 to B, 1 to C, 3 to both D and E, and then 1 to S.
Mm-hmm. So kind of a range. So good, good. Well, hopefully by the end of this, you'll be experts. Okay, great.
Go ahead. Oh, there's still 2 more votes coming in. Oh.
So they're getting dollars. Yeah, okay. Good. Okay, great. So that just kind of gives us a sense. So yeah, if you want to go to then the overview.
I just shared the results with everyone, so you can take a look at that.
I guess you have to go back now, right? Okay, so what we were going to do today is just do a high-level overview of cash and our two-part approach. You all should have received a community benefit profile for your ACH area. So we're going to walk through those. We just want to make sure that it's clear and you understand it and, kind of do some interpretation. Then we want to just speak about, other offerings just in terms of further analyses that could be done, any engagements, kind of looking at investments. And then we also wanted to really hear from you and dive deeper into community health needs assessments and the issue of wellness funds, and then open this up to Q&A. Great, so CASH is otherwise known as the Center to Advance Community Health and Equity. You're going to hear about us today and what we do, and I've shared the staff. And, we really we're new. We launched actually officially in December, but we've been in a planning mode through a Robert Wood Johnson Foundation grant for almost 2 years, of getting this thing kind of up and going. And, we really are about providing tools, and you're going to see one of the tools that we have, but that isn't the only tool, but also technical assistance, with a particular emphasis on how do you take this data in partnership with others to advance health and well-being in communities. We are particularly interested in looking at the data and being able to call out where health inequities are concentrated to begin to look at where resources are allocated. So I think, this is our main goal, is really to advance community health and well-being in communities with social, economic, and health inequities. And these are just our core principles. One of the things that I think we're very mindful of just want to share with you today is community benefit. That resource is one of many resources in the community. And, we really want to work in partnership with hospitals. We don't want it to feel like they are the only ones that need to come to the table and pony up. I think there are other organizations who also have, or entities, who have a responsibility, much like community benefit. So we really believe that there's this shared ownership for health. So much like the work that's being done in the ACH, we're all accountable to each other as well as to the community. The other piece that I've already spoken to, I think, is this issue of health equity. I think it's all in service to that. Also, we want to do this in creation with others, like we all have a part to play, so it really is, it's more than one of us. And I think this notion of contextual analysis, the data is the data, but I think we want to bring in kind of other tools, other ways of looking at it to make it real and make it alive. For what it is that we're trying to do. So this work is a two-part approach, and I'm not going to, bore you with kind of all of the history, but, this database that you're going to be, hearing about today is actually has when it started out at George Washington, they developed it as a prototype, and there were 9 states in it. And moved then to getting RWJF to actually fund RTI, or Research Triangle Institute International, to create and build out this database. So they are housing that. They're the ones who are managing kind of all of that data. And when the funding came out for this, there was a really strong preference and a belief that that data shouldn't be put out unless there was a technical assistance component to that. And they put out an RFP, and there were 6 organizations that were asked to apply, and we were named. So we really are doing this in partnership with RTI and building that out together. We have an initial set of TA offerings, so some of the data that you're seeing, this is kind of a little bit deeper. We do have a website. You know, we are involved in some pilots where we're actually kind of doing some mashup of different kinds of data, this being one of them and others, to really put that kind of notion to practice, to really look at where resources are being allocated as really a helpful tool. Great.
So I think now.
Great. So now I'm going to shift to Kevin.
Okay. So, in essence, what you see on the slide here is our commitment to look at ways in which we reduce duplication of effort. There are an immense array, particularly in our urban communities, of organizations and entities that are engaged in a lot of small-scale efforts, a lot of what our child psychologists would call parallel play. And this work is really about bringing analytics and other resources and on-the-ground deliberation to look at how we better align and focus our efforts where health inequities are concentrated. And to do so in a way that takes us beyond a project mentality and more towards really thinking about how institutions change the way they do business. In essence, a more systems approach to this work. So just a bit on the healthcare side of the equation. Everybody's using the term transformation these days, and it is basically a process of moving our hospital-based healthcare delivery and financing system from a fee-for-service model to a model where, in essence, the incentives shift from filling beds and conducting procedures to keeping people healthy and out in our communities. This chart is a way of looking at, on two different axes. On the vertical axis is that transition from fee-for-service to global payment. There are a variety of different mechanisms supported at multiple levels, including by the Center for Medicare and Medicaid services that involve assuming increasing risk, financial risk for keeping people healthy. The horizontal axis gets to how do we begin to build the institution, organizational, and collaborative capacity to better analyze and move from an orientation that is about serving individuals and or diseases and body parts, and moving to how do we use data to identify that there are populations that we have with common diagnoses, and begin to identify and dig into the factors that are influencing that, moving from there, from the notion of a panel, in essence what we've described as population health management, to identifying the fact that we have geographic concentrations of these same inequities beyond our own defined populations in the broader community, and how do we align resources to address those. All of that moving us from hospital as an acute care body shop to health systems that share risk with a broad spectrum of stakeholders for improving outcomes in the broader community. So in essence, this is about the shifting of financial incentives, assuming increasing financial risk. That, of course, is happening at different rates across the country, given the high penetration of Kaiser in our markets. In some ways, that is moving more rapidly. In California, we have more experience between groups like Kaiser and our Medi-Cal managed care plans. I think in some ways offer opportunities to accelerate this work here in California. It also comes with increasing transparency as we get more and more access to what people are paying for services and what are some of the drivers related to those. So all of this is really leads us to not how we confront each other, but how do we really look together at how do we better leverage existing resources. So I thought at this point it'd be good to, as we go into Eliza's walkthrough, to have a clear understanding of what it is that is the charge of hospitals and health systems as it relates to their compliance obligations. I won't take a lot of time on any of these slides. You can read more details, but in essence, hospitals have to conduct a community health needs assessment every year. There are underlying expectations that as part of conducting that community health needs assessment, you've engaged folks with expertise in public health, not necessarily the public health agencies, but clearly that is the source of that expertise in many of our communities, but also that you are securing input from folks who are in underserved, low income, and racially and ethnically diverse communities. That is an expectation of hospitals. One additional element that's not on this slide that was part of the final regulations is that when folks ask questions to hospitals and health systems of how they are about their implementation strategies and the things that they do, hospitals are now required to publish their responses to input to inquiries by communities. Another key element is that that hospitals must include a description of the communities as they've defined them. And that's a geographic definition that hospitals have to offer. They often identify service areas and or a jurisdictional boundary like a county, but that's a key element that we'll come back to in a moment. So this is an example of a study we did for the CDC a few years ago where we looked at 15 regions across the country and looked at how different hospitals define their communities. This is a particular municipality that will go unnamed, and this is using a tool that we helped develop called the Vulnerable Populations Footprint Tool, and this is on the Community Commons. If you just go to chna.org, you can see this, and you can type in any city or county anywhere in the country, and it automatically bring up the hospitals, the federally qualified health centers, as you see in the little crosses on there, and it brings up 3 core metrics. One of those are the percentage of the population under the federal poverty line. A second is the high school non-completion rate, and those are at the census tract level. What you see on this map in the census tracts with that are in tan or orange, depending on what your color orientation is, are those census tracts in this particular municipality where 40% or more of the population lives under the federal poverty line and or has high school non-completion rate. The green areas is a third metric which looks at those census tracts where 100% where the percentage of the population that is 100% above the top quintile in household income. So you see the affluent. The point is to show you that you see 2 different boundaries, one in lavender and one in black. And you can see the the 2 hospitals that define their communities in black looks like a gerrymandered district around the low-income census tracts. So that is based upon how they defined their community in their community health needs assessment. And it's important to know that these kinds of data, using these kinds of GIS maps, enable us to get at the degree to which these particular hospitals are fulfilling the letter and intent of the expectations in how they define their communities. Next slide. So on the implementation strategy, on the compliance side, they have to publish it in the same year that their CHNA is conducted, have to describe how they're going to address selected priority needs, as well as provide justification for identified priority needs that they're not addressing. And generally speaking, they limit their focus to what they view as their hospital internal expertise. Many hospitals move beyond this and take what we would call more of an excellence or quality improvement approach, using GIS technology to identify the sub-regions where health inequities are concentrated, using tools just like the map that we provided. Then go to the next level to identify, engage, and map the community assets. In essence, what are other stakeholders that share an interest in improving health, and how can we work together? And then we work together to strategically design a comprehensive strategy that leverages those assets, establish common metrics, determine resource allocations, and optimally identify ways in which we may share returns on those investments. Next slide.
Great.
So I'm going to turn it over to Eliza, and she's going to talk a little bit about the profiles that we provided to each of you.
Sure. Just before we dive into this next section, is there any questions at all that have come up for anybody about anything that was shared?
This is Lori from Sonoma County. I don't think we received a profile, or at least I'm not aware that we did.
Okay.
It went to Kristen on Monday as part of the package for the backbone call. But we can do that.
Lori, yeah, I was just going to say I can sort it out and send it right now.
Thank you.
Great, thanks. Great.
Okay. So now with all the kind of background set up, I'll just take us through a quick walkthrough of what was included in these profiles, and then we'll move forward from there of kind of how they can be interpreted and further analyses or work that can be done based off of them. So in these profiles, the first section is the kind of community benefit overview. So there's the list of all of the tax-exempt hospitals in each defined site area, the financial information, so their overall operating expenses, and then the total community benefit expenses, as well as a breakdown of the community benefit expenditures by the specific categories. So that should all be on the first or second page, depending on how many hospitals there are in your specific site. And there's a couple kind of caveats listed along there that we'll get into just after this, but if hospitals report in aggregate, so if they file together, those numbers might seem a bit larger or smaller, but we'll get into kind of how you can start to interpret some of that information. And so the data source for those sections were both from the Community Benefit Insight tool, which Sue mentioned before, which we partner with RTI. So RTI International manages that database, and they've actually just this week updated the 2015 data. So there's a couple-year data lag in the reporting schedule, but the 2015 data is now available on the site as of Monday. So these profiles contain the 2014 990 data.
Of course they do.
Yeah. And so the second part of the profiles is this narrative analysis, and that included a review of both the CHNA and implementation strategy. And the information that we highlighted here is the defined community, as Kevin spoke to before, the importance of understanding that, as well as if they included health disparities as a priority in their CHNA process. And we called out any of the significant health needs that they had identified. And then through the implementation strategy, we listed the priority needs that they had identified and the inclusion of any targeted either geographic area or population groups with concentrations of inequities within those priority need areas.
Just a quick note on the issue of health disparities. One of the things that we looked at and look at in general in the review of these CHNAs is the degree to which they identify race and ethnicity in general versus the degree to which they do a drill down to looking at race and ethnicity and associated health outcomes in a geographic context, that is identifying specific census tracts where those inequities are concentrated in the associated distribution of race and ethnicity within those populations. So it's an additional drill down that increasingly hospitals across the country are doing, but you can quickly get at on the CHNAs whether or not that is occurring.
And the data sources for that information are the CHNA and implementation strategies, which come directly from each facility's website. They're required to make their CHNAs publicly available, so those are all available on their hospitals' websites, as well as while not required, most implementation strategies are posted alongside.
Mm-hmm. And just to add, so this week, hopefully you got, we created an additional document that has the links. So for each of the sites, you can actually then go to the link on there to see the 2016 and or 2017 data that she's referencing. So it's like an easy, so if you really are bored and you want to kind of go in and dive deeper, some of them are many, many pages long, but it might be just really an interesting exercise. So.
And then the third part of these profiles that we've provided is what we're calling the community benefit glossary. So it includes key terms, a very brief highlight of the requirements and processes pertaining to the community benefit area. And that is also directly from the IRS 990, as well as some of the information included in the CBI tool. And so this is just for everyone who maybe hasn't looked at their profile yet or hasn't had a copy of them, those 3 sections that I'm referring to. So section 1 is kind of the overview of the breakdown of the different financial information. The second page there is what would be the analysis of the CHNA and implementation strategy information. And then that third page is the glossary of key terms and processes. And so with that now walk through, we'll move back to Kevin, and I can help as well in how to interpret and then perform some further analyses with this data.
Okay, so I guess the first thing we'll put on the table are the caveats, and those are important to recognize. So Eliza referenced the time lag in data available. It is a function of the process of the hospitals reporting their data to the IRS. They can submit requests for extensions, and accommodating those extensions can delay submittals for 6 months to a year. And then there is the process of that getting uploaded and cleaned up into this database. Generally speaking, yields at least a 2-year lag in that process. The good news, bad news is that when we look at least comparisons over time, we have not as of yet seen a significant shift in how resources are allocated by hospitals. That is, the vast majority of resources, at least in the near term, are being allocated towards financial assistance for uninsured and underinsured populations and public pay shortfalls. And most of those services are for treatment of what we would view as preventable conditions in ED and inpatient settings. So that, of course, is what we want to look at changing over time, and that the changes in financial incentives will be significant drivers of that process. There's also important to know that we have health systems who can report in the aggregate. The IRS allows that. Some health systems across the country still do report at the facility level. That enables us to get a better sense at how a particular facility is responding to the dynamics in their particular area. We have worked with the colleagues at the University of Colorado who have developed an algorithm that enables us to do estimates. We're looking at ways in which to strengthen that algorithm, looking at payer mix, demographics, and other issues, so with that we at least have the potential to do that drill down to the facility level as an estimate, and offer that up in engaging local stakeholders as an opportunity for that facility to share their actual data as opposed to that estimate. But that's a complicating factor in getting at the regional level an understanding of how resources are allocated. The other issue that bears mentioning is that the IRS doesn't and probably couldn't require a strict delineation of what counts and what doesn't count as community benefit. And some hospitals and health systems take a more rigorous approach to what they would be willing to count than others. Some, for example, if they were to include a diabetes or a cardiovascular disease education program, they wouldn't do it if they were doing it in their hospitals for all populations. They would be inclined to only count it if, in fact, it focused predominantly on underinsured populations and was actually held in low-income communities where that was concentrated. So we have to accept the data as they are. So the kinds of things that we look for in both reviewing directly the implementation and community health needs assessment is evidence that there is some efforts to partner across hospitals and across other stakeholders, and perhaps more importantly, how are they moving beyond what we have represent as collaboration and community health needs assessments, which for the most part involves different hospitals coming together to share the cost to hire a consultant to conduct that community health needs assessment, looking at ways in which we deepen that engagement and thinking beyond simply the co-investment in a consultant to thinking together, how do we do the deeper drill downs within communities, and then perhaps most importantly, how do we translate conducting assessments together to co-investing in the activities that we design together and implement together in partnership with diverse stakeholders. That is our interest in particular as it relates to the work of the center. How do we move to that level? How do we connect those dots? I've mentioned the issue of defining community. We try to look at ways in which to strengthen that focus. Again, if everyone defines their community as a county, that is fine. But we also know that in most of our counties, there are specific census tracts where those health inequities are concentrated, and how do we come together to address them? And then how do we go beyond addressing the symptoms of poor health to addressing the real drivers of poor health? And in working with hospitals and health systems around the country, there's growing recognition that they have to move beyond a proprietary approach. That is, doing something that we put our brand on it means we're probably not going to have a measurable impact because there's just not sufficient dose, not sufficient intensity of investment. If we take the route of doing it alone, and we have to look at ways in which we come together with others, leverage our resources, and focus them in an intensive way where those inequities are concentrated. And then last but not least on those priorities, as we've found in reviewing a lot of the community health needs assessments and how priorities are set, one thing that we have found across the country is that the history, for the most part, is that community stakeholders, diverse community stakeholders, have not had a significant role in actually setting the priorities. It's usually brought internally, and or if there are community stakeholders, they have a limited role in determining what the priorities are. And there's a tendency among hospitals to select priorities for which they have expertise for and set aside those, like, for example, looking at health and housing, to say, well, that we really don't have expertise in that, so we're not going to select that as a priority. And subsequently miss the opportunity of using that identified priority as a way to really leverage the engagement of those that do have that expertise in their particular area.
So before we move to this next stage, I want to, because this is a lot.
Yeah.
A couple things that I just wanted to kind of put out there, and then I want to open it up for questions that we didn't specifically say, or at least I didn't think So you're seeing your data, and there isn't a yardstick at this point that says, gosh, mine's 4% and this one is X percent. you know, just in terms of a comparison. So I think that's just something to know. One thing that I also didn't call out when I was speaking earlier is, you know, the issue of transparency. We've kind of used that. So this data has been publicly available, so to speak, but it's not very easy to get it. And so one of the drivers behind this was to make this data available. And I think what we're trying to do is, so there it is, like, what does it mean? What should you be looking at? You know, kind of all of those different things. And we have, it was a little tense at the beginning with RWJ because I think we had a different kind of vision. I think, you know, initially it's like they wanted to get the hospitals, and we kind of have been more like, yeah, they have a responsibility, but I think we really, you know, want to work with them. So I want to stop and then see what kind of questions that you have, you know, regarding your specific profile or anything that, you know, Kevin has spoken to. Or whatever question, doesn't So it's all clear.
This is Tiffany from Long Beach. I have a question. In our profile, we have 2 hospitals that are part of larger hospital systems, which I'm sure is the case for a lot of other communities. Also, I guess one thing that's going in our favor is the community health needs assessment is pooled, like you described, with Memorial Care, Dignity Health, Kaiser, and actually the Long Beach Health Department all doing their community health needs assessment together. So we are part of that process. But something I've had a real challenge obtaining, and I couldn't through your links either, is what is the actual community benefit contribution of, for example, St. Mary Medical Center, which is a Dignity Health hospital. What's that actual contribution in the community of Long Beach? Because what you've provided is Dignity Health as a whole, which is a 39 hospital system across 3 states. So I know that, you know, cash and in-kind contributions of $37.9 million isn't going to Long Beach. A smaller portion of that, I wish.
Sure it is, Tiffany.
Yeah, so like a smaller portion of that is going through the St. Mary Medical Center community benefits. And same with Memorial Care. I think it's an 8 hospital system across 2 counties. I don't know like what portion of that is coming to Long Beach. Is there any way to tease that out?
Well, there is, as I described earlier, we had this algorithm, and that's an example of a further level of analysis support that we could provide. And part of that, you know, in this case, and it involves ways in which to engage colleagues at Dignity with whom we have good working relationships to get at those data. And I'll just back up and say, you know, one of the things I've been hearing, I've been doing this work for about 25 years, and one of the things that I always hear from folks is exactly what you asked, which is, I don't know, you know, I'm not even sure what to ask our hospitals other than, will you write us a check? Because we don't know what they're currently doing. So these data are intended to position us to ask that more specific question. So at the very least, it could be, if you were doing this on your own, to engage your colleague to say, gosh, all we see on your 990 as it's reported here are these aggregate figures. Might it be possible for you to provide us with your St. Mary's specific data? And their response may be, gosh, I don't think so. You know, that's somebody in a different department, and I don't think I can get that out of them. Well, what we can do with this algorithm is to provide an approximation, and with that approximation, explore with them are they comfortable with that approximation being shared, or would they like to provide a more accurate and current figure? So it's a process of engagement, of supporting that kind of increased transparency.
Mm-hmm.
Okay, thank you.
You bet.
Is Mickey Carpenter, are you on? I thought, okay. Because I know in San Gabriel, they've just gone through a process where actually all of their partner hospitals for their group have actually shared this data, right? So they actually have made it available. And I know, Deborah, you're on, and you know, since you're fairly new, I don't want to put you on the spot, but apparently I am. I don't know if you have anything to share on that, or if Alyssa, I thought I saw maybe Alyssa, anybody from San Gabriel, just to kind of share a little bit about that.
This is Deborah. Unfortunately, I'm not really able to add very much at this time. I do know that it is an impressive group that's within the Healthy San Gabriel Valley Initiative, and some of the community health assessment has been shared and with the group, with working with the City of Hope, Kaiser, Sisters Hospital, as part of our effort. I know that we did an analysis of all the hospitals and what their benefit and how we could all work together. So I don't know if that's helpful at all. I'm still on the learning curve on this, but very exciting work though.
Great.
I'm not surprised to hear that. I did work with Citrus Valley now going back over 20 years. They had strong leadership for work in this arena back then. So I'm glad to hear that that trend is continuing.
Great. Any other questions before we move on?
There's more time at the end.
Yeah, we have time at the end, so great.
So some of the further analyses that are available, as I referenced earlier, is we have an array of GIS tools that we use to do these overlays and to drill down further, to get there are other metrics available to us to look at specific social determinants of health, ranging from looking at issues around food insecurity to homelessness, to a variety of other kinds of metrics that help provide that deeper overlay. And in California, one of the tools that has been underutilized dramatically is that the Office of Statewide Health Planning and Development has utilization data for all the hospitals, and it's possible to draw from that, at least at the zip code level, to document by institution and payer source the prevention quality indicators, or what we used to call ambulatory care sensitive conditions, and then map those utilization data in a way that really helps make the business case, in essence, for how do we invest in addressing those issues. So we're that is some additional work that we could provide. The other is, we included in the profiles what were the identified priority areas, and particularly in counties where we have multiple hospitals, we'll see some overlap. Often, however, the priorities are defined fairly broadly, and really the next stage work is to drill down into exactly what different hospitals and other stakeholders are doing as it relates to those priorities, so we can really begin to identify where the leverage opportunities are. So that is really one of the most important opportunities to be exploring, particularly as we'll touch on later as it relates to the establishment of wellness funds. They are really one of the key sources for how do we collaboratively invest and focus our resources. We've already talked about the allocations as it relates to doing the estimates and the drill down to the facility level. And then really looking at where are the opportunities across sectors. A major focus of our work across the country is looking at the intersection between hospitals, healthcare, community benefit, and community development resources, looking at the at the issue, for example, of the Community Reinvestment Act and ways in which financial institutions fulfill their CRA obligations by investing in things like affordable housing, grocery stores, child care centers, and the like. And we are engaged with a number of stakeholders looking at how to align those kinds of investments with how do we address health inequities in local communities. So that we are doing that in California as well, working with large CDFIs like the Low Income Investment Fund, with the enterprise communities and others to look at how to better align those kinds of efforts. And that's certainly something we could bring to bear in the context of this initiative. And I've already touched on the GIS overlays with preventable ED and inpatient utilization.
I just want to emphasize, I think, given that you're working in the accountable communities for health, I'm not sure how many of you have engaged the CDFIs. You probably have hospitals, but I think it's another group to have a relationship and really understanding what and how they're investing in the community. And, you know, kind of back to our notion of shared ownership. I mean, so they both have an obligation to invest, and particularly investing in low-income communities. So how do you actually make sure it is in alignment, right? So I think that's an important piece.
Terrific.
Okay.
We're on our last section here.
Yeah.
So one of the things we're interested in hearing from folks on is, where are you in your development process, i.e. putting together a wellness fund? And some underlying questions are, what are you looking at as the key sources for funding? Have you reached any agreed upon priorities for that fund? Is there a formula for partner contributions? And I recognize this last issue may be on the horizon, but it's important to think early on of, if we achieve reductions, how do we plan to share those? How might we be investing in an infrastructure that supports ongoing monitoring and going forward, for example? So we'd like to open it up and hear from you on that.
Mm-hmm.
If you're speaking, you're on remote.
Okay. Remote.
You're remote, yeah. Mute, I'm sorry.
And I think just to tag on, you know, and Barb, you know, Pat, Laura, chime in as well. You know, I think this is one of the elements. I think when, you know, we were discussing between the two kind of programs about this, I think there is interest in community benefit maybe being a contributor into a wellness fund, and, you know, how might that work, you know, those kinds of things. So I think just really like to hear from you, you know, around where you're at. You know, do you have community benefit dollars? If you have a wellness fund that's established, like, are they in there, and how is it being used also? So just open it up.
Oh, hi, this is Lori from Sonoma County.
Hey, Lori.
Oh, okay, thank you. I wasn't sure if you could hear me.
Yeah.
So I'm going to preface this by saying I've been on a bit of the periphery in our efforts around this part of the Accountable Communities for Health work, but so I would say we're sort of refocusing on the wellness fund part of this project, and working on, we actually have some funding that has been, you know, put into a place, you know, that we're calling a wellness fund, but we're still working on sort of the process around developing our wellness fund. We did an analysis a year or so ago about our sort of the opportunities for us to develop this, and then for various reasons had to sort of set that aside, and now we're coming back to it to talk about you know, picking up that work. So I would say we're early, still very early in this, but our oversight committee for our Accountable Communities for Health project is talking about this and talking about priorities and how to, how to evaluate requests. There's just a lot of more work we have to do on this. I'm kind of jumping around here because I don't have all the details, but I'd sure like to hear from other areas who might be further along in their wellness fund development. And I think Kristen, if she was on this call, could probably, give you a few more details about this. But anyway, lots of questions here. Yes.
Yeah.
Yeah.
So Laura, this is Sue. So thank you. I mean, I think everybody's in different places, and I think that's perfectly okay. Are you referencing the third sector report?
Yeah. Yes.
Okay. Yeah. So, so Jessica, who's on, actually led a discussion or hosted a discussion last week with our group around that report. So we want to thank you. It was really, I think when Jessica was telling me about it, she said it was transformative. And so, we shared that. So thank you for that. Yeah.
I can't take any credit for any of that. I wasn't actually part of that, but thank you. Good to hear that.
Yeah. Hi, Lori. This is Jessica. And I just want to sort of echo that. Really appreciate the sharing from Kristen and your community. Has gotten us so much further down the road. I just really appreciate it.
Great. Thank you. Thank you.
So Lori, this is Kevin. I know I have some familiarity with the work that you folks are doing in Sonoma County, and that includes an MOU at least a couple years ago that really I was impressed with, declaring a commitment to do exactly the kind of resource sharing and alignment that we have been talking about. And it seemed to lead strongly towards this concept of a wellness fund. So and I know that that you folks also have support from that you are one of the sites for the Ventures Initiative that also I think has at least an element of looking at this issue of creative financing in this regard. So I would guess that a number of the sites will look to Sonoma and what are some of the emerging lessons there in this process. I appreciate you stepping forward, and this is an issue of great interest to us and looking at ways in which to advance this work in other parts of the country. So for others on the phone,
can I just say one more thing? I'm sorry, I meant to say this when I was talking a minute ago. With regard to the wellness fund and the issue of community benefit dollars, I don't think we have had that conversation specifically yet here in Sonoma County. I could be wrong about that, but we do have our health action infrastructure, the multi-stakeholder community health body that meets together and is working on this issue of as part of the Accountable Communities for Health, the Wellness Fund, and discussing all this. And there's been lots of great conversations. We also have had a community health needs assessment process that involved Health Action and other community partners with the hospitals, and they do the shared, consultant thing. But the part about what happens then with the funds, with the community benefit spending, as far as I know, is still kind of a black box for us.
Yep.
Yeah, this is Laura Hogan. I just thought I would kind of piggyback on that last comment from Lori Houston to say that I think a lot of communities are in that same position of perhaps working now with an entity to set up their wellness fund, and certainly thinking about the kinds of funding sources that might eventually populate and hoping to design a plan for how they have funds flow into the wellness fund. But I think this webinar is part of a fairly early exploration for most of the Catalyst communities as they think about the Wellness Fund and its and overall sustainability for the ACH. I know Jeremy Cantor is on the call, and he may have, again, a bird's eye view across the community of some comments that would be useful at this point.
Jeremy, if you're talking, you're on mute.
That's right. Yeah. I didn't realize you. Yeah.
Yeah. Well, maybe he's had to step away from the call. But,
okay.
Yeah, I think that this information is incredibly useful for people to be thinking about this opportunity as it and how it might relate to their community, especially because, as Lori said, there are people around the ACH collaborative table who either come from hospitals or potentially have participated in some way in a community benefit or a needs assessment in past years. So either have been a recipient of funding or have been an informant to a community benefit process. So this is a great way of getting consistent information across that leadership team and collaborative partners of what a community benefit looks like, what a needs assessment process looks like, and really taking the learnings from you guys and spreading that across the collaborative to then begin those conversations, do some planning, think about how the opportunity of a community needs assessment might play against what the ACH happens to be doing.
Which I'm not sure that we called it out, but you know, the hospitals now are in the process of doing that. And so I know we talked about this last week on the accelerator site call, but you know, I don't know how many of you are actually actively engaged in that. Some of you, I think, have data committees or performance measurement committees, and you know, that may or may not, some of that work just in terms of supporting what happens in that needs assessment may you know, be supported or could be collaborated there. And certainly what comes out of this has such an incredible opportunity to shape and inform your work, you know, just in terms of, you know, what you're trying to do together. So I don't know how many of you, like just in terms of your active involvement, one of the accelerator sites is actually a hospital. And, you know, I don't think they're on Lake County, but, you know, she said in the past, we've just thrown money at a consultant, but that this year, just given their involvement in this, they really want to change it up and do it a little bit differently. So I don't know if any of you want to speak to kind of your involvement in that process or any things about that, just to kind of add that. Okay.
I'd just like to put a point on this issue of the community health needs assessment process. You may or may not have noted that most of what we are talking about in this work is how resources are currently spent and how to better align and focus them on health inequities going forward. The larger issue of community health needs assessments is that for the most part, they have been conducted in meeting a compliance obligation by hospitals. It's also important to note that a variety of other stakeholders are conducting community health assessments at any time. Local public health agencies to meet their accreditation requirements, federally qualified health centers for their Section 330 funding, community action agencies to focus their resources. So in essence, there are a lot of assessments going on. There's a lot of data. And our real charge is how do we better align these efforts going forward. I want to make sure, sometimes we tend to get focused on community health needs assessments, and in the process we lose track that really what we're trying to do is to better target and focus and tie resource allocations to achieving measurable outcomes. And that's a challenge as a part of this larger transformation process, because often those conducting the community health needs assessments or leading that process within the hospitals are in a functional part of the organization that's disconnected from, let's say, the ACO functioning, the building population health management capacity in the organization, the efforts to reduce readmissions, the efforts to engage in risk-based contracts. And that's a disconnect that we have to begin to break down, so that when we are doing the assessments, it's actually thinking about how do we work together with these other parts of the organization in a way that it helps advance our efforts to transform our institution. I just want to note that that connection is often not made within the hospitals, and we need to look at ways in which we empower and strengthen the hands of those with that charge in those organizations, so that connection is effectively made.
Mm-hmm. Well, one of the things that when you were talking, so part of that kind of 18-month planning process, I think we all, I did a lot of interviews of people to kind of get a sense of a variety of different things to help to design this. What we heard over and over again was, I don't know how to talk to hospitals. Mm-hmm. And I don't know how to engage in conversation with them. So I think it's, for some, if you have a great relationship with them, I think that's really good. But for some, it's very awkward. So I just want to kind of name that and put that out there. The other thing that I think one of our national advisory members, James Corbett, we had a really great meeting this last year, and he was just naming all of the different people in the hospital, right? So you think you're going to this person, but there's all of these other people, right? So there's a community benefit person who might be at a local hospital, and then you've got like maybe a system level. There's a population health person, and sometimes they're not necessarily the same, and they may or may not talk to each other. You have the fiscal people who are filing the paperwork, and then you have a CEO who may or may not even know how the investments are being made. So I think, spending time kind of understanding the landscape, may also be helpful, I think. So questions? You're a quiet group.
Hey Sue, this is Christina from Long Beach.
Hi.
So one of the questions we were thinking as, we're listening to everything that's happening, our hospitals, since, they're larger networks, and there are other Kachi sites that have Dignity Health probably within their location. Should we partner up and approach all together at in their San Francisco headquarters? What are your thoughts around that?
Mm-hmm. Yeah, what do you think, Kevin?
Your question is, should we partner up
with the other sites that have Dignity?
Because there's a lot of Dignity Health hospitals in Sacramento.
I see.
And
yeah.
I think it's worth exploring when you say partner up. It could be going directly to colleagues at the system level to try to get a better understanding of what Dignity may be doing in other sites. If you're interested in looking at what kinds of innovations are in play. Pablo Bravo is the VP for Community Health at Dignity Health, and often a partner in a variety of other efforts. So we could certainly help make that connection.
Mm-hmm. Yeah, I think that's a great point. I think even if it's, increasing their understanding of what is the ACH and what's going on. I think Kaiser is another great example, right? Where they're in a number of different communities.
I serve on the board of a large health system, Trinity Health, and we part of our work internally as a board in helping to drive change within the system is look at ways in which we highlight the more advanced regions within our system and highlight what they're doing as a way of driving change in others. So the larger question that you're asking is, gosh, what are there things that other Dignity regions are doing that we could be doing, that we're just not aware that is an option. And again, we can help you get at that kind of information.
Yeah, because we have a good relationship with our local Dignity Health Hospital, but the trend I've seen is that there's less and less local power, and it's being consolidated a lot more with their corporate headquarters currently in San Francisco. They're also going to change that to Chicago when they do their merger. So
I think they're going to keep a lot of functions in the San Francisco office, but technically they are moving their corporate office.
But they tend to make very large, they make large community benefit contributions to the community across their 3 states. But a lot of those decisions are really held in San Francisco, and so I'm kind of wondering, maybe as a group, for those CACHI sites that have Dignity Health Hospitals, if we can sort of approach as a group and say, this is what we're doing with our Accountable Communities of Health initiative across California, and it also affects your hospitals in these communities. If there's a way that they can give us community benefit dollars out of their larger bucket that they have held at their corporate, not the smaller buckets they have at the local level.
That is absolutely perfect and exactly what we kind of support, that we are looking at doing, and then using that by extension as ways in which to leverage deeper engagement of other hospitals in your region as well.
Okay.
I.e. memorial care.
Yeah, I think in memorial care, they're not in any other CACHI sites, so we'll just have to deal with them.
Yep.
Thank you.
We can be helpful.
Okay, Sue, can you help us do that?
Sure.
Absolutely.
By 5, I'm on it. Any other questions?
Yeah, this is Lori again from Sonoma County, and I just want to echo that idea, or say that I think that's a great idea, because our 3 large hospitals here are all part of larger hospital systems, and this is something that comes up again and again. So yes, so it's St. Joseph now, it's Providence that's running that, the larger picture, and then we have Kaiser, of course, and then the Sutter organization. So which I think the Sacramento is where they're headquartered. So I think this is a great idea, and I think we'd be interested in hearing more about this approach.
Terrific.
Great.
Other questions or comments, observations?
Anything that strikes you about this? Is anybody's, like the data folks, like their mind is spinning about possibilities, or?
Well, this is Lori again. First of all, I just want to thank you both, Kevin and Sue, and all the people involved in doing those profiles. I haven't actually seen ours yet, but this is super valuable information, and the information that you shared in this webinar today too is just really, really great stuff, and addresses a lot of questions I know I've had about this issue of community benefit dollars. So just want to thank you.
Thank you.
Thank you for coming and participating.
Well, I think we might be in a position to giving a little bit of your day back to you if there are no other questions.
We want to keep you just for the sake of it, but and also, as some of you know, ponder is one of my favorite words. And so if, as you're reflecting on all of this, if you have any questions or, want to follow up, please let us know. So we just want to make sure it's clear. So great. Barb, anything, any questions, any closing, any other thoughts?
Just a word of thanks on behalf of all of the catalysts. I really appreciated the profiles you put together and this session to help folks understand the data and what the possibilities are for how to leverage that data. As I was looking at the questions, Kevin, you teed up, I was thinking, yeah, those are all the questions, and we're really at question 1, which is developing it. But I think what is exciting about what's happening with the EHs is it's the place to have the strategy conversation, so that it's not about community benefit dollars in and of themselves and about a program to invest those dollars in, but rather how do you leverage community benefit dollars along with other potential investments and then use those dollars collectively to advance a strategy reflected by the portfolio of interventions to really drive improvements in particular community health issues. So I think we're, but those are also interrelated, and I think that's why communities are sort of toggling back and forth between priorities, which is the embedded in the portfolio, and designing the wellness fund, because to answer the questions that you identify, which is how do you allocate resources, you have to have done the portfolio work. So this is all very iterative and independent, and this is an important piece of the puzzle that I think you've highlighted here that can stimulate a lot of those conversations locally. So long-winded thanks on behalf of our team and our communities, and we look forward to further conversations around this.
Terrific.
Great.
Thank you.
Thanks, Barb. Thanks to everybody. Have a great day.
Thank you.
Okay, because I'm going blind. How many people were actually on? Oh, Nicole.
You're on 24.
Oh, nice. Yeah. Was there chats?
I didn't see anything.
Oh,